Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is ART in Adults and Adolescents and Adherence to ART. And the speaker is Dr. Priya Patil. Dr. Priya Patil ma'am is currently working as a Deputy Director for the COE JJ Hospital and alternate nodal officer for both the ARTCs at JJH. She is an Associate Professor of Medicine in Grand Government Medical College and Sir JJ Group of Hospitals, Baikala, Mumbai. She has completed her MBBS and MD from BGMC, Pune. She has done many thesis studies on HIV, out of which one is published. We welcome you, ma'am, for today's session and request you to start the session.
Yeah, thank you, Dr. Shweta. I am very thankful to iTech for giving me this opportunity, and we are happy to resume our RDLS sessions. So today's topic, as Madam said, it is national regarding ART in adults and adolescents, and also about adherence. Now, this is a very important topic. So I will be discussing in these the different issues like goals of antiretroviral therapy, then about principles of antiretroviral therapy. So first we are going to discuss some basics regarding ART. Then clinical pharmacology of commonly used ARV drugs. So this is a revision for most of the medical officers. They already know about it, but it is always better to revise the basics. So considerations before initiation of ART. Then when to start ART in adults and adolescents. Monitoring of patients on ART, how we are going to monitor our patients on ART. Then regarding immune reconstitution and inflammatory syndrome and how to recognize it. And most important, last not but the least, adherence to ART. Now coming to ART in adults and adolescents. So basically now we are seeing that after the ART medications have been there for some time now, there has been a rapid decline in HIV related mortality and also morbidity due to the wider availability of these ARTs, like, ARVs which are affordable, more efficacious and less toxic. So what is ART? It is a combination of at least 3 antiretroviral drugs from different classes to inhibit the replication of HIV and reduce viremia to undetectable levels. So when we do a viral load, we see that report is TND, that is target not detected. So that is the reduction of viremia to undetectable level. Then transformation of HIV infection. Now because of this ART drugs which are available free of cost in so many ART centers, which are ART centers also, they are available everywhere now. So what has happened is HIV has become, it has transferred into a chronic manageable illness, because initially when HIV infection began and there were cases of AIDS, so it was like a virtual death sentence at that time. But now it has become a chronic manageable illness, because just like how diabetes and hypertension, they are chronic illnesses and they need to be on lifetime medications. Similarly, HIV has also become a chronic manageable illness. So ART was earlier known as highly active ART, HAART, and as combination ART, so CART. So these are the different nomenclatures which are used for ART. Now, because of ART, we have continued suppression of viral replication, and that, what is the impact of that? That leads to restoration of immune response, that is increased CD4. So once there is a restoration of immune response, that leads to slowing of disease progression, and that leads to reduced frequency of opportunistic infections, and this leads to, in turn, improvement in the quality of life and increased longevity. So that is the main goal of our antiretroviral treatment, that the patient should have improvement in the quality of life and an increase in the lifespan. And that is possible because of the impact of ART. So that's why here the goals of ART are listed. So we have clinical goals, that is increased survival and improvement in quality of life. Virological goals, where we have greatest possible sustained reduction in the viral load. Then immunological goals, where there is immune reconstitution, that is both quantitative as well as qualitative. Then therapeutic goals, like rational sequencing of drugs in a manner that achieves clinical, virological, and immunological goals, while maintaining future treatment options, limiting drug toxicity, and facilitating adherence. What does this mean? Means we should have proper, first line, second line, third line, there are options. When the patient fails on the first line, then he still has a second line option open. And after that, there is a still third line option open for him. So there is a sequential therapeutic options are there. And at the same time, there is limitation of drug toxicity, and the regimens are also in such a manner that they're easy to take. Like the first line is so easy. It's only TLD, one tablet per day. But as we go from first line to second line and from second line to third line, the pill burden will go on increasing. That is why there is a rational sequencing of drugs. So that whenever we are, we want to switch from one line and to first line to second or second to third, many times we are getting SASEP referrals for that. But my request to all the medical officers is that we should be, sure that there is a failure on the treatment. Many times the viral load is high because of non-adherence, and that is not picked up, unfortunately, because generally the counselors, now we are going to discuss how to calculate the adherence and the adherence percentage. But I have a serious doubt whether really counselors are applying that formula and calculating, or it's just, they just ask the patient, goli kha rahe kya? And if the answer is yes, they write 95% or 100% adherence. That goes on in many centers. So adherence, assessment of adherence is very important, and we should not immediately, like it should not be so easy that chalo first line failure, immediately go to second line. But we should be sure that it is actual failure, and we should be sure of the adherence of the patient, and then we can have the options of changing these subsequent treatment lines. And what are the preventive goals of ART? Reduction of HIV transmission by suppression of viral load. So these are the different goals. Now coming to the mechanism of action and targets of ARV drugs. Now this is a schematic model from the time the virus enters the CD4 cell and till it multiplies. So you can see that this is a cycle. So initially, the virus, when it is going to enter the cell, there will be CD4 receptor and there are co-receptors. So there is a CXCR4 receptor and there is a CCR5 receptor. So basically, we should know this mechanism of this life cycle of HIV, because then we can easily understand at what level the drugs are acting. So once the HIV binds to these receptors, then it will fuse with the cell wall and then cell membrane, and it has an entry inside. After it enters inside, we know that HIV is an RNA virus. So now with this key enzyme called reverse transcriptase, what will the HIV RNA? It will create a HIV DNA template, and then this HIV DNA goes inside the host nucleus, the cell nucleus, and it integrates with the nucleus with the help of another key enzymes, that is integrase. So as we are discussing this life cycle, when we again discuss, I'll tell you about the drugs. So just see that where all these drugs are acting. So integrase is one key enzyme where there will be another drug acting, and then again there is a messenger RNA which is transcripted from this host cell DNA or the host cell nucleus, into which the HIV DNA has integrated. Now this messenger RNA is going to assemble, cleave the proteins, and then help in the assembly and budding of the HIV virus proteins. And finally, then with the assembly and budding, the HIV virus replicates and you have many viral copies coming out of the cell. So now we'll see again from this life cycle where all the drugs are acting. So we saw that when the HIV binds with the co-receptors, so that time you have a CCR5 receptor. So there the drug maraviroc has an action. Then there are fusion inhibitors which are acting at the time of uncoating and penetrating. So when the HIV virus has a cell coat, and when it uncoats and penetrates the cell, at that level there are fusion inhibitors like enfuvirtide. So this is an injectable drug. It is not there in the program, but at least we should know about these drugs. Then after the entry of the drug, when we saw that the HIV DNA is being transcribed from HIV RNA, that time you have this reverse transcriptase enzyme, which is a key enzyme. And here there are very important group of inhibitors known as reverse transcription inhibitors. And they are of two types, NRTI and NNRTI. And you also have a nucleotide reverse transcriptase inhibitors. Then at the level of integration with the host DNA, we have integrase inhibitors or integrase strand inhibitors. So INSTIs. Then at the level of protein cleavage by the mRNA, you have protease inhibitors. So these are the different protease, and we'll see which of the protease inhibitors are available in our program. So these are the different targets where the ARV drugs are acting. So coming to the list of the drugs as we just now discussed. So we have the reverse transcriptase inhibitors are of two or three types. One is a nucleoside reverse transcriptase inhibitors. So which are the drugs available under our program? So we have zidovudine. Stavudine has been already phased out, as you all know. Then we are having lamivudine and abacavir. Now, when we talk about the NRTI backbone, okay, so always, in NACO guidelines also you see that in the third line, we retain the NRTI backbone. So this NRTI backbone is these drugs. So you have this lamivudine, zidovudine, abacavir, or nucleotide reverse transcriptase inhibitor, that is tenofovir. So these are constituting the NRTI backbone. So in this NRTI, we have both nucleoside reverse transcriptase inhibitors as well as nucleotide reverse transcriptase inhibitor, that is tenofovir. So tenofovir, zidovudine, lamivudine, abacavir. These are our NRTI backbone drugs. Now, in the nucleotide reverse transcriptase inhibitors, there is another drug, tenofovir alafenamide, which this is not available in our program yet, but it is useful in cases where there is tenofovir nephrotoxicity. Now, this tenofovir alafenamide has almost it does not have any nephrotoxicity as well as any bone toxicity. So sometimes in patients who are hepatitis B positive, they and who have nephrotoxicity, they are prescribed this tenofovir alafenamide. Coming to fusion inhibitor, as we already said, enfuvirtide or T20. This is not there in the program, just for our knowledge. Then you have the NNRTI drugs, that is non-nucleoside reverse transcriptase inhibitors. So these were the good old nevirapine and efavirenz, which we used to use. Now we are not, we are using them only in selective indications. So right now, they are being phased out and available only for some special circumstances. Then integrase inhibitors, as we saw, the two drugs which are available in our program are dolutegravir and raltegravir, and the other drugs are listed. You can see in the list. CCR5 entry inhibitor we saw, maraviroc was the drug. Protease inhibitor available in our programs are lopinavir, atazanavir, darunavir, and ritonavir. So ritonavir, always we have this combination, that is, it is a ritonavir boosted combination. So lopinavir with ritonavir, or atazanavir ritonavir, or darunavir ritonavir. And then lastly, post-attachment maturation inhibitor. So after that, when when the virion matures, that time this drug acts, and that is ibalizumab. So now coming to the different drugs and their adverse effects. So coming to NRTIs. So then you have our first line ART constitutes of tenofovir, lamivudine, and DTG. So we'll be seeing the doses and adverse effects. So tenofovir, the dose is 300 milligram once daily, and the major effects are nephrotoxicity and bone demineralization and bone toxicity. So any patient who complains of, say, nausea, vomiting, and who is on tenofovir, we should be suspecting nephrotoxicity. Again, any patient who complains of bone pains, hip pain, all over the body, always suspect bone toxicity. And as we'll discuss, regular monitoring for renal toxicity is very important for tenofovir. So 6 monthly creatinine is necessary. Then coming to zidovudine, the dose is 300 milligram twice daily. And the adverse effects, the most common adverse effect of zidovudine is anemia, and it also can cause severe bone marrow suppression, neutropenia, and then GI intolerance, sometimes headache, insomnia. You can have myopathy, lactic acidosis, skin and nail hyperpigmentation, that is also common. And if you see the CBC on any patient with zidovudine, the MCV is raised. MCV is more than 100. So there is a macrocytosis, and sometimes zidovudine can cause also pancreatitis. Then coming to lamivudine, the dose is either 150 milligram twice daily or it is 300 milligram once daily. Lamivudine has minimal toxicity, but there are cases of lamivudine rash, though rare, because at Center of Excellence in JJ, we are handling many suscept cases, and we are seeing some cases where there is lamivudine rash, and the typical history is rash with every regimen, because every regimen has lamivudine. So if with all regimens, so with ZLN or ZLE or TLD or abacavir, lamivudine, everywhere in each regimen, because lamivudine is always there, patient is not tolerating any regimen, and that is the history, and the patient is also frustrated. So if you have a patient like that, rash with every regimen, then it is likely to be lamivudine rash, and so you need to do a suscept referral for that. Then coming to abacavir, the dose is 300 milligram twice daily or 600 milligram once daily. So the most dreaded side effect of abacavir is hypersensitivity reaction in 3% to 5%, and that can be fatal. So we need to be on alert, on our guard. Now, where we are using mostly abacavir? In patients who are having creatinine which is deranged at the baseline, or patients who have for nephrotoxicity, we switch to abacavir. So in such cases, you have to warn the patient that patient should immediately report if he has any fever or rash or any fatigue, any symptoms like nausea, vomiting. Sometimes there can be non-specific symptoms. The rash may come late. So initially patient has nausea, vomiting, the respiratory symptoms like breathlessness and high-grade fever. So these are the different symptoms of the hypersensitivity reaction. So prompt, stopping the drug, and then we should never re-challenge the drug, because that can be fatal. So once you have suspected abacavir hypersensitivity, we will never be re-challenging the drug. Then coming to Adherence, the dose is 600 milligram once daily. Bedtime administration is suggested to reduce the CNS side effects, because it can cause severe insomnia and bad dreams, etc. And food-related advice for Adherence will be avoid taking after high-fat meals. So it should be a simple meal, low-fat meal, and at bedtime. The adverse effects are CNS mainly, that is dizziness, somnolence or insomnia, confusion, hallucinations, agitations, and personality changes. Rash also can occur, but it is much less common than with nevirapine. Nevirapine, the dose is 200 milligram once daily for 14 days, followed by 200 milligram twice daily. Now we are hardly using nevirapine nowadays, but just I'll shortly mention the side effects, that is hepatitis, and sometimes it can be life-threatening hepatic toxicity, skin rash, and sometimes we have all of us have seen the severe Stevens-Johnson syndrome because of nevirapine, which is a very severe reaction with mucosal involvement and also toxic epidermal necrolysis. Then patients who develop severe hepatic toxicity or grade 4 skin rashes should never again be re-challenged with nevirapine. Now coming to integrase inhibitors. So DTG, dolutegravir, was the first approved for its usage by US FDA way back in 2013, and it was recommended by WHO in 2019. The NACO Technical Resource Group approved its usage since July 2020. So NACO recommends dolutegravir as the preferred drug for treatment of HIV positive adults, adolescents, and children. For children, it is age more than 6 years with body weight more than 20 kg under the NACP. So DTG is an orally bioavailable integrase strand inhibitor with activity against both HIV type 1 and type 2. So that is the best part of DTG. So whether it is HIV 1 or HIV 2, it is equally effective. And that's why we can use it in both these infections. Then it is currently the preferred drug in the first line and also in the second line treatment regimens. Then coming to the side effects of integrase strand inhibitors. So DTG is the preferred INSTI in the program. The dose is 50 milligram once daily. What are the adverse effects? In some patients, patient can have insomnia. So they complain of sleep disturbances. And if such patients, who have persistent sleep disturbances, they have to be reviewed and managed accordingly. So maybe we can add some sedatives with appropriate consultation if that is really affecting the daily routine. But if still the patient has persistent issues, then a SUSEP referral may be indicated to change. Now, it is important to take cognizance of the adverse effects which the patient complains. Many times what happens is patient is complaining these side effects, but this is I have got the feedback from many patients as well, who come to SUSEP, that they have a lot of toxicity, and then they say कि बहुत बार बोला, doctor को भी बोला, सबको बोला. Whenever we find out that patient is not adhering to drugs, then only the adherence counseling is done. But nobody is going into the depth why the patient is non-adherent. So if the cause of non-adherence is the drug toxicity, then it is a job. Counselor ने विचारायला पाहिजे प्रत्येक पेशंटला की का गोळ्या घेत नाही, आणि गोळ्यांच्या साइड इफेक्ट मुळे जर का पेशंट गोळ्या घेत नसेल तर ते तुमच्या मेडिकल ऑफिसर पर्यंत ते तुम्ही पोहोचवायला पाहिजे. कधी कधी मेडिकल ऑफिसर बिझी असतात, त्यांना वेळ नसतो एवढं पेशंटची बोलायला, बराबर सगळं पेशंट निघतात. ऍटलीस्ट काउन्सिलरने विचारायला पाहिजे की ज्यांचं नॉन अडिअरन्स हे गोळ्यांच्या साइड इफेक्ट मुळे असतो, त्यांना तुम्ही नुसतं अडिअरन्स काउन्सिलिंग आणि गोळ्या खा म्हणून चालणार नाही. त्यांना तुम्ही ते ड्रग टॉक्सिसिटीसाठी मेडिकल ऑफिसरकडे घेऊन जाणं गरजेचं आहे. अँड द मेडिकल ऑफिसर, इफ यू सी दॅट द non-adherence is because of drug adverse effect, please look into it. What is the kind of adverse effect? What is the drug toxicity? Just address that. You can do some investigations for diagnosis of that toxicity. Like if the patient is not tolerating tenofovir, patient is complaining of vomiting, maybe we can do serum creatinine. Or if you are suspecting pancreatitis, we can do amylase. Whatever is the toxicity, please do some investigation, and you can refer to SUSEP also for the drug toxicity. And please mention that if the reason for reason for referral for SUSEP is drug toxicity, that has to be mentioned so that we can prioritize such patients in our SUSEP assessment, because we have a lot of SUSEP case load. So routine cases where there is drug failure, that may take some 1 or 2 weeks, sometimes. But if the patient is having severe toxicity, then it is a priority. So please mention that it is drug toxicity and the patient is off drugs. Patient चे drug थांबलेले आहेत, असं जर का तुम्ही आम्हाला व्यवस्थित कम्युनिकेट केलं तर मग ते पेशंट आम्ही पहिले त्याला प्रायोरिटी वाईज बघू शकतो. तर आता समजा एखाद्या पेशंटला खूपच सिव्हिअर इन्सोमनिया आहे की तो जॉबही करू शकत नाही, तर तो गोळ्याचा अडेरन्स त्याचा नसणार. तर अशा केसमध्ये नुसतं अडेरन्स काउन्सिलिंग करत राहिलो तर पेशंट गोळ्या खाणार नाही आणि काहीच म्हणजे सॉर्ट आउट होत नाही प्रॉब्लेम. तर असा जर का सिव्हिअर प्रॉब्लेम असेल तर त्याचं वेळेवर SUSEP रेफरल होणं आवश्यक आहे. Then other side effects like headache, dizziness, tiredness, allergic reactions, these are rare, but some patients we have seen who complain of insomnia. Another issue with DTG is weight gain. Weight gain is a known side effect, so strict monitoring. So please do a baseline weight before the DTG based ART started, so that we know how much weight gain has been occurring. And whenever the patient once monthly is coming, we need to document the weight, and strict monitoring is required. Then raltegravir is also available in case there are some toxicity with DTG. So the dose of raltegravir is 400 milligram twice daily, and the adverse effects can be rhabdomyolysis, myopathy, myalgia, diarrhea, fever, rash, SJ syndrome, toxic epidermal necrolysis, hepatitis, and hepatic failure, and again insomnia. Also, along with even DTG may have some hepatotoxicity, but before we conclude that it is DTG related hepatotoxicity, we have to rule out other causes, because hepatotoxicity can be seen very commonly with other things like anti-TB drugs. Then patient can have viral infections or any other thing. So basically, once we rule out other causes, then we can attribute the hepatotoxicity to DTG, and accordingly we decide on the regimen. Then coming to drug interactions, with important drug interactions along with DTG. So now whenever we are using these drugs, we should know that these drugs can interact with dolutegravir, and so accordingly we can manage it. So the drugs are listed here. Amiodarone, so you have to use an alternative antimalarial agent. Carbamazine, use DTG twice daily or substitute with an alternative anticonvulsant agent. Phenytoin and phenobarbital, use an alternative, so anticonvulsant. So whenever a patient is on DTG, phenytoin and phenobarbital should be avoided for treating seizures. Then dofetilide, which is an antiarrhythmic agent, we don't use it so much. So again, it has an interaction. Metformin, commonly it is used for metformin is very frequently used for diabetics, because diabetes is a common comorbidity. So limit the daily dose of metformin to 1000 when used with DTG, and monitor glycemic control. Now, many times I get query from medical officers that patient is diabetic, so can we use DTG? So in diabetics, definitely we can use dolutegravir, but the only issue is the questions will be addressed at the end of the session, preferably, because this is a very lengthy lecture. I mean, this session, and I have to cover so many things. So at the end of the session, we can take the questions. So metformin maximum dose is 1000 milligram. Now, if this 1000 milligram metformin is not able to sufficiently control the blood sugar, then the patient we can use other oral hypoglycemic agents. So there are so many other oral hypoglycemic agents which can be used along whenever the patient is on DTG. So glimepiride is there, glaclazide is there. There are so many other drugs now, newer drugs are also there, gliptins, so we can use them. Then coming to polyvalent cation products containing aluminum, calcium, iron, magnesium, and zinc. So very commonly, many patients take multivitamins, some supplements, antacids. So remember that multivitamins, we should remember that use DTG at least 2 hours before or at least 6 hours after supplements containing these polyvalent cations. So sometimes females who are on iron regimens, they are taking iron supplementation, or somebody is taking antacids. You have to explain to the patient that DTG should be taken 2 hours before, or if they are taking the supplementation, then there should be a 6 hours gap after that taking of the supplementation. That we have to explain to the patient. Then rifampicin again has an important interaction. So whenever rifampicin is used, there is an enzyme activation, and so the DTG levels will fall, and that's why we use DTG in double dose. So DTG dose is 50 milligram twice daily. So along with rifampicin, because of enzyme activation. And so whenever a patient is on TB drugs, now this also I've seen sometimes there is a lapse from the ART centers that even though patient is taking TB drugs, DTG is going on only in the OD dose. This I've seen many times. It happens that the ART center is not aware. Patient has been taking TB drugs from private, and he may not tell it, he may not communicate to the ART center. And so the ART center is giving DTG only in the usual dose. So it's very important for the ART center to be aware that if the patient has TB, and if whenever the TB is diagnosed, definitely when ART has to be co-prescribed with TB drugs, we have to give extra 50 mg dose of dolutegravir, or we can substitute with rifabutin. Now currently rifabutin is not so available, so it's the 50 mg twice daily dose. Then coming with the other adverse effects of P protease inhibitors. So atazanavir, the dose is 300 milligram of atazanavir and 100 mg of ritonavir. And the commonest adverse effect is unconjugated hyperbilirubinemia, which is actually harmless. So only if there is unconjugated bilirubin which is high with the liver enzymes normal, there is no need to change the drug. Then there can be lipid abnormalities. The lipid profile can be abnormal. There can be hyperglycemia, fat maldistribution, nephrolithiasis, cholelithiasis, and PR prolongation. Lopinavir, ritonavir, the dose is 200 milligram of lopinavir with 50 mg ritonavir, fixed dose tablet, 2 tablets twice daily. The adverse effects are diarrhea, nausea, vomiting. Sometimes there is a severe GI intolerance, abnormal lipid profiles, and glucose intolerance. Darunavir is used in the dose of 600 milligram twice a day, and along with that, ritonavir 100 milligram twice daily. So there is a hepatotoxicity which can also occur with darunavir. There can be skin rash in 10% cases, diarrhea can occur, nausea, headache, hyperlipidemia, serum transaminase elevation can occur, and hyperglycemia. Coming to ritonavir, it is 100 milligram once or twice daily according to the PI to be boosted. The common adverse effects are GI intolerance, that is diarrhea, nausea, vomiting, and abdominal pain. Rarely, neurological disturbances can occur. Now coming to considerations before ART initiation. So this is very important, that before ART, what are the things we should consider? So the patient should be adequately prepared, and informed consent should be taken from the patient or from the caregiver in case the patient is minor. So properly the patient has to be counseled. It's not कि गड़बड़ में सब चालू किया फटाक से, NACO का गाइडलाइन है सेम डे ART, तो फटाफट चलो पेशेंट आया, उसको बिठाया और प्रिस्क्राइब करके उसके हाथ में गोली थमा दी, ऐसे नहीं है. तो आपको वी हैव टू एडिक्वेटली प्रिपेयर द पेशेंट. पेशेंट के मन की तैयारी, मानसिक तैयारी होनी चाहिए उसकी कि ये गोली बराबर से खाएगा. अभी जो ससेप में मैं देख रही हूँ कि बहुत सारे पेशेंट्स TLD और डोलोटेग्रेव रेजिमेंट पे वायरल लोड्स हाई करके ससेप रेफरल बहुत सारे आ रहे हैं. तो इसमें प्रॉब्लम क्या है कि हमने पेशेंट का बराबर प्रिपेयर नहीं किया है. उसका मतलब पेशेंट ठीक से गोली नहीं खा रहा है, उसकी वजह से ये हो रहा है. तो ये सबकी जिम्मेदारी है कि पेशेंट को बराबर से काउंसलिंग होना ही है. सो ट्रीटमेंट हैज टू बी स्टार्टेड बेस्ड ऑन द पर्सन्स इन्फॉर्म्ड डिसीजन and preparedness to initiate the ART. A caregiver has to be identified for each person to provide adequate support, so that caregiver is going to see whether the patient is having good compliance, good adherence or not. Then all patients with clinical stages 3 and 4 and those with CD4 less than 350 need to be put on CPT. Now CPT also, it's very important, the timing of CPT. So just recently I had a referral at SASEP. A patient was admitted in skin ward. So patient was started on ART and CPT simultaneously. And then patient got a Stevens-Johnson syndrome and a severe reaction. Now we don't know when such a thing happens, whether the rash is because of CPT or it is because of any ART drug. That is why the timing of CPT. So please start CPT first. Watch for 3-4 days. Whether the patient has tolerated CPT, whether there is no reaction, and then you can initiate the ART later after the patient has tolerated CPT. Please do not start ART and CPT simultaneously, because if there is a rash to sulfa in the CPT, then we will not still know. We are not sure the SJ syndrome has happened because of CPT or the other drugs. So that is very important to be remembered. All patients are to be screened for TB using the 4-symptom tool. And those who do not have TB need to be started on tuberculosis preventive therapy, that is TPT or IPT, in addition to ART. Again, there is no need to hurry that immediately you start the IPT. First, I think we should start the ART, see whether it is tolerating it. So CPT first, then ART, and later on, after the patient is comfortable, having no side effects, then you can initiate the IPT. Everything if you start at the same time, then the patient will not know which the side effects are occurring to which drugs. It is very important that opportunistic infections should be treated or stabilized before commencing ART. Always remember that ART is never life-saving. Life-saving is the management of opportunistic infections. So any patient who is seriously ill, ART is never an emergency. The OI treatment is an emergency. That is very important, and we have to explain the patients and the relatives about this. Then the only exceptions, that which two infections are exceptions where commencing ART may be the preferred treatment. It is Mycobacterium avium complex, MAC, and progressive multifocal leukoencephalopathy, where commencing ART is the preferred treatment. Now coming to management of the clinical conditions before the ART initiation. So any undiagnosed, one second. So any undiagnosed active infection with fever, what is the action? First, we have to diagnose and treat that fever, whatever is the cause of fever. Sometimes it is a tropical infection like malaria, dengue, whatever. So first, we need to diagnose that and start ART when stable. Then coming to tuberculosis. Now ART should be started as soon as possible within 2 weeks of initiating TB treatment, regardless of CD4 cell count among CL HIV, except when except when the signs and symptoms of meningitis are present. Okay, so we'll have another table later on. So basically for TB, we have to start the treatment within 2 weeks. If there is a severe TB meningitis, maybe there can be some delay also. Then coming to pneumocystis pneumonia, again it is very important to treat PCP first, and after the PCP treatment is completed, then we have to start ART. So whenever we are treating the OI first, we are reducing the antigen load, and then that reduces the chance of severe iris. So that is the rationale that why we are treating these infections first completely, because otherwise for especially PCP, if it is the iris, the patient can have severe fulminant iris, then he can have severe hypoxia and respiratory failure. That's why we complete the PCP treatment and then give the ART. Similarly for invasive fungal disease, now coming to esophageal candidiasis, sometimes because of esophageal candidiasis, basically the patient cannot even swallow the tablets properly. It is very painful. So first we have to treat the esophageal candidiasis, and then once the patient can comfortably swallow, we have to start ART. Similarly for cryptococcal meningitis, if we start ART early, then there can be a life-threatening CNS iris causing cerebral edema, which the patient can lose his life. So very important, treat the cryptococcal meningitis completely. The whole course of amphotericin B should be over, and then initiate ART. And similarly for other invasive fungal diseases like penicillosis, histoplasmosis, in all of these, start ART only when the patient is stabilized or the OI treatment is completed. For bacterial pneumonia, again, treat the pneumonia first and start ART when treatment is completed. Malaria, first malaria treatment, then ART after completion of treatment. If there is a drug reaction, actively patient is having a rash, we should never start ART during that acute drug reaction. Otherwise, we will not know whether the ART is tolerated or there is a drug reaction for the ART also. Acute diarrhea, that can reduce the absorption of ART. So first diagnose that, treat it properly, and then start ART when the diarrhea is controlled, stabilized properly. Coming to non-severe anemia, where HB is less than 9, we can start ART if no other cause for anemia is found. So we can do a just an investigation like B12 level, ferritin level for iron deficiency, and if they are normal, so then sometimes the HIV per se is a cause of anemia. HIV infection can cause marrow suppression. So in that case, we can start ART, but obviously we have to avoid zidovudine in such cases. Then coming to evaluation of CD4 cutoffs for ART initiation over time. So this is the journey from 1995 to till date. that the thresholds of CD4s went on increasing. So you can see in 1995 to 2005, the CD4 was initiated less than 200. So at that time, we used to start ART with the CD4 less than 200. That did have an impact on AIDS mortality. So patient with AIDS, they had the mortality reduced and major OI incidence. Then after that, from 2005 to 2010, the CD4 threshold became less than, so CD4 of less than or equal to 350. So this had impact on HIV, again, impact on HIV mortality and disease progression and comorbidities like TB. Then in the 2010 to 13, that time, based on the observational studies, the ART initiation was now increased to CD4 more than 350, and this had an impact on disease progression and non-AIDS events. Then we had, based on studies, HPT and 052, reduction of HIV transmission among HIV discordant couples. So one of the couple, one person is positive and one is negative, discordant couple. So there was a reduction documented of HIV transmission among such couples, and also the risk of TB in adults. So it had an impact on HIV incidence. And then 2015, there was Temprano and START studies where the ART initiation was now, the threshold became more than or equal to 500 cells. So that again had an impact on severe HIV morbidity and disease progression without increasing in the severe adverse events. And now we can see that we have come to this stage where we are giving HIV to all. So now, as you all know, when to start ART, the answer is treat all. So all people with confirmed HIV infection should be referred to the ART center for registration into HIV care, comprehensive clinical and lab evaluation to assess the baseline status, and treatment of pre-existing opportunistic infections, treatment preparedness, counseling, and rapid ART initiation, preferably the same days unless contraindicated otherwise. So preferably the same day for whom? Where there is no symptom, 4S symptom is not there, we are not suspecting any infection, patient is young with no comorbidities. So in such cases, we can have it on the same day. Otherwise, those patients who have some fever, who are having some opportunistic infection, then we need to evaluate that, and later on the patient will be initiated on ART. So basically, we should remember that all persons diagnosed with HIV infection should be initiated on ART regardless of the CD4 count or WHO clinical stage or age group or population subgroups. Only the timing of the ART, we have to see if there is an active OI. The timing of the ART is only after the completion of treatment of that active OI. But even in those patients, definitely we are going to start ART as soon as possible. Now, what ART is to start? So, coming to fixed drug combinations and their advantages. So, you can see all the advantages which are listed here when we are using fixed drug combinations. So, they are easy to prescribe. There is an improved patient adherence with them. Minimizes, so fixed drugs combinations, you have 3 drugs in the same pill. So we are using TLD combination. So it's a fixed drug combination. All 3 drugs are there in the same pill. So just patient has a comfort of taking only 1 pill per day. We must remember that patients have to keep on taking these drugs whole lifetime. So, as easy, so the lesser the pill burden, the most better it is. And fixed drug combinations will give this minimum pill burden. So therefore, there is a minimized chance of developing treatment failure. There is an easy drug procurement and distribution, and it is more acceptable and tolerated by the patient. Now coming to the recommended choice of first-line regimen by NACO. So as we all know, dolutegravir containing regimens are the preferred first-line treatment for all HIV-positive adults, adolescents, and children who are more than 20 kg and more than 6 years. So that is under the NACP since July 2020. So the basic principle for first-line ART for treatment naive adult and adolescent patient is to use a triple drug combination from two different classes of ARVs. So the first line ART essentially comprises of an NRTI backbone. As we saw, what is this NRTI backbone? These are the nucleotide or nucleoside reverse transcriptase inhibitors. So preferably it is non-thymidine, that is tenofovir plus lamivudine. So, and one INSTI, that is preferably DTG. That's how our first line regimen is TLD. In NACP, based on the evidence supporting better efficacy and fewer side effects, the preferred first line ART regimen for all PLI HIV with age more than 10 years and weight for more than 30 kgs is tenofovir 300 milligram, lamivudine 300 milligram plus dolutegravir 50 mg regimen, that is TLD, as fixed dose combination in a single pill once a day at a fixed time every day as per the patient's convenience. Now, the single pill of TLD should be taken preferably at bedtime, and instances where additional dose of DTG is indicated should be taken preferably in the morning. So bedtime is preferable because at that time patient is at home generally. So that's why he's sure to take the pill. Now again, even whenever we are saying that it should be taken at bedtime, whatever timing, we need to ask the patient's job and at what time he will be at home. Many times in my SASEP meetings where I am conducting the SASEP and inquiring about adherence, what I have found out is, suppose the patient is still at the job and then the time comes to take the pill, whenever he is at job, he is skipping. So that's why it is the job of the ART medical officers as well as counselors to ask which is the most suitable time where he is definitely not going to miss it. Suppose he is at the time of his, he is in the office or he is at his job at the time of his pill, when he is supposed to take the pill, then he might miss it. So that is very important while initiating the therapy. So please fix the time after discussing the patient, what is his job and at what time he is definitely going to be at home and he is going to take the pill. Then patients with severe diabetes and hypertension should be monitored more closely for toxicity. Patients starting on DTG should be monitored for blood glucose every 6 monthly and also for weight gain upon monthly visits. Appropriate physical activity should be advised to prevent the weight gain. So that again has to be done while counseling. So we must advise regarding exercise. Now coming to alternate first line ART in adults and adolescents. So for PLHI with body weight less than 30 kg, the alternate first line is abacavir 600 with lamivudine 300 and DTG once daily in the morning or any fixed time as per patient's convenience. All patients with high, that is above upper limit of normal for the lab. Now that's serum creatinine more than 1.3. Please remember that 1.2 is the cutoff for most labs. So if the creatinine is above 1.2, it's going 1.3, maybe you can again observe for the next month. So it's increasing 1.3, 1 has become 4. Please change it timely. That if you just for 6 months, 9 months, you don't act and the patient is having creatinine, continuing to have creatinine 1.5, 1.6, it is climbing, then patient can have irreversible nephrotoxicity or irreversible tubular toxicity, and then the creatinine will never come back to normal once you stop tenofovir. So that is again a take-home message with today's session. I have seen that there is no prompt action by ART medical officers. काउंसलर्स के लिए भी यह संदेश है कि अगर आपको नोटिस हुआ क्रिएटिनिन पेशेंट का ज्यादा है तो तुरंत आप पेशेंट को लेके जाइए आपके मेडिकल ऑफिसर के पास. We cannot tolerate, we cannot go on having tenofovir in a patient whose creatinine is 1.3 or more than that. So that is very important. So there we have to switch to abacavir. Lamivudine dose is as per creatinine clearance. So suppose the creatinine clearance is more than 30 ml per minute, then lamivudine can be along with abacavir used in full dose, but with patient being closely monitored. So we need to monitor the creatinine and see if it is increasing. If the creatinine again increases and the creatinine clearance falls less than 30 ml per minute, then we have to now readjust the lamivudine dose. So it can be 150 mg OD or 100 mg OD or 50 mg OD as per the patient's create clearance. So that is very important. So abacavir will be full dose 600 mg. Now suppose the lamivudine dose comes to 150 mg OD. Then this abacavir 300 milligram tablet is there, and there is a combination of abacavir 300 with lamivudine 150. So that these can be given. So plain abacavir 300 with abacavir 300 along with the combination of 150, that can be given easily. And again, dolutegravir dose does not change. It is 50 mg once daily, even with a high creatinine. Then PLHIV on rifampicin containing ATT regimen. Again and again, that is very important to remember. So TLD, fix FDC, 1 tablet once daily in the morning or any fixed time as per patient's convenience, plus additional dose of DTG to be provided 12 hours after taking their regular dose until 2 weeks after completion of AKT. So that is very important. Now suppose the patient is taking TLD, say at morning 8 o'clock. Then the second dose of additional DTG will be night 8 p.m. Or if the patient is taking tablet at night 9 o'clock, then morning 9 a.m. we can give the additional dose of DTG. And how many days we have to continue that additional? Now suppose ATT is stopped. आज ATT बंद हो गया उसका, तो आज ही हमको DTG का extra dose नहीं बंद करना है. DTG extra dose will go on for 2 weeks more. Why? Because the enzymes will still remain activated. So still the DTG level will be less for 2 weeks. After 2 weeks, that complete enzyme activation, that effect is gone. So even after stopping rifampicin, that enzyme activation continues for 2 weeks. That's why 2 weeks after the AKT is stopped, we have to continue that DTG additional dose, and then after 2 weeks, we have to stop the additional 50 mg DTG. Then women of childbearing potential who opt out, who do not wish to take DTG based ART after the adequate and optimal counseling, then there if we have to give the TLE regimen, and if efavirenz is contraindicated, like where the patient is having HIV-2 infection or HIV-1 and 2 infection, or there is a prior history of NNRT exposure, then in that case we have to give tenofovir TL with lopinavir ritonavir combination. Now coming to the rapid ART initiation algorithm. So just I'll go through it fast because we have to complete the whole lecture now, only less time is there. Now, so basically we have to see the symptom screening is important. So 4S symptoms, if they are yes, then we need to evaluate. If there is no 4S, then we need to see clinical examination. If the 4S symptom is yes for any symptom, then we have to rule out TB. So appropriate diagnosis management, we have to do the X-ray, gene expert, all that we have to start doing. And there is an expert consultation for diagnosis of TB and referral if required. Now, if there is no 4S symptom, the answer to 4S is no. Then physical examination, we need to rule out any important signs, like if there is a fever on examination, temperature more than 39, respiratory rate more than 30. So if the patient is very tachypneic, respiratory is 40, he may have PCP pneumonia. So that we need to rule out definitely. Heart rate if it is more than 120, or the patient is having altered mental status like confusion, strange behavior, reduced consciousness, यानी उसको कुछ CNS OI के लक्षण है. Other neurological conditions like seizures, paralysis, difficulty in talking. So any such symptom or sign is there, please refer for admission. ऐसे पेशेंट को एडमिट करना ही जरूरी है. तो आपको देखना है कहाँ एडमिट करवाना है. आपके ART सेंटर का कुछ मेडिकल कॉलेज अटैच्ड है, जैसे नायर, सायन, JJ, they can admit at their medical college itself. They have to just contact the medicine department. If not, then you can refer the nearest medical college. You can refer this patient for admission. So this is very important, that prompt admission will save the life of the patient. Then okay, so if the patient does not have any serious signs of any serious illness, and there is no comorbid, then we have to see whether there is any comorbid condition. For example, whether the patient has TB or whether the patient has known history of any kidney disease or uncontrolled diabetes or hypertension. If that is so, then again we have to evaluate the patient for that comorbid condition. So if the patient has TB, then we should see whether he's gene expert positive, whether all the cultures are sent, and he has to be referred if there is an expert opinion taken. Again, for kidney disease, we have to evaluate the patient's creatinine, whether he has any acidosis, whether USG is done, uncontrolled diabetes, what are the sugars, and whether treatment for this uncontrolled diabetes has started, hypertension, whether he is on medication. So all that we have to first evaluate and treat that comorbid condition, and then we can start the ART. However, if the patient does not have anything, so no 4S symptom on physical examination, no serious illness, and no comorbid condition, then in that case, we can see for the readiness assessment. So for that, we need to do the preparedness counseling via our counselors. And for any PLHI with psychosocial concerns or comorbid substance abuse, okay, then we have to involve relevant persons like family. So patient is an addict, is taking alcohol, no, then maybe then definitely we need to involve the family members, relatives, peers, counselors for enhanced counseling. So we have to advise him regarding stopping his addiction and whether he's prepared to take the ART. So that support he'll require. So there, day one preferably, we can initiate ART if all these things are ruled out. So then in that case, we initiate ART. So all these things like patient is not having any comorbidity, any serious illness, no 4S symptom, and no substance abuse, then we initiate the ART on the same day. In that case, if the patient is mentally ready, is willing, and he is prepared, so then we have to dispense the ART for 1 month and concurrently send samples for CD4 count and other baseline investigations like CBC, all the investigations for as per NACO guidelines. And then within 3 to 5 days, preferably, patient needs to follow up. So when he comes to follow up, all the review test results will be there. The CBC report, the X-ray report, sputum gene expert, if at all, if it is indicated, all those reports will be there. And if the test reports are not normal, he has to be called back to the ART center as soon as possible within 2 weeks of ART initiation. The ART counselor has to call all patients and ask about general well-being within the 2 weeks of ART initiation, and the medical officer should do the appropriate management of advanced disease, adjustment in the regimen, OI prophylaxis, comorbidity management, etc. So ART initiation, as soon as appropriate action has been taken as per NACO guidelines, depending on the reason for deferral. So in the case where, as we saw initially, that there were some 4S symptoms, or there was some serious illness, or there was some psychosocial issues, in that situation, once that treatment OI is treated and whatever the psychosocial issues or the comorbidity like diabetes and all, that is treated and addressed, after that the ART initiation has to happen as soon as possible. Now coming to monitoring of patients on ART, as I said earlier, this is a lengthy session, so please bear with me. I'll try to finish as fast as possible, but these are all important points, so we will have to spend some time on these some of these issues. So coming to the monitoring, follow-up and monitoring is essential in patients initiated on the ART to track the clinical progress, monitor their well-being, and to identify any adverse drug reactions and toxicities. So this includes clinical monitoring and lab monitoring. Clinical monitoring includes monitoring of adherence to ART as well. That is very, very important. And I request all the ART medical officers to take up this, especially in the initial months, whether the patient is tolerating the ART and whether the adherence is good. Because if we leave the job only to counselors, many times it is missed. Patients may not confide everything to the counselor, and patient may only want to talk only to the doctors. So that's why clinical monitoring includes monitoring of adherence to ART, and this has to be also done by medical officers as along with the other team. The client should be monitored every month for clinical progress, side effects of the ARVs, and treatment adherence. Clinical and lab evaluations are carried out at specified intervals for patients on ART. So the monitoring and the follow-up schedule for patients on ART. So what all we have to monitor? Body weight every visit. In addition, in children, we have to see the height also for evaluation of growth. Then treatment adherence, every visit we need to evaluate. Clinical monitoring and T staging, again every visit. 4S symptom TB screening, every visit it is important. Screening for common non-communicable diseases like hypertension and diabetes mellitus, it has to be done every 6 months or symptom directed. So sometimes the patient has some symptoms like polyuria, polydipsia, some urinary tract infection. Then if we are suspecting patient may be having diabetes, we can do that as per the symptoms immediately. Lab evaluation based on ART regimen every 6 months or symptom directed. CD4 count must be done every 6 months, but later on in those patients where the CD4 is more than 350 and plasma viral load is less than 1000, then in that case we can stop doing every 6 monthly CD4. Then instead we should do every 1 year along with the viral load assay. Viral load at 6 months, 12 months, and then every 12 months, provided the viral load is less than 1000. Then coming to the continuing with the clinical monitoring. So we need to do monthly clinical evaluation, as we said, body weight, overall well-being, and any new symptoms or signs have to be asked for. Because once the patient is on ART, he might develop iris, and some infections may come up now again. Some occult infections may become overt. So that's why we should be on alert for that. So any new symptoms and signs we need to ask. 4S symptom screening for TB. Every visit it is must. Then monthly treatment adherence evaluation. Very, very important. Please do pill count and on that basis do the adherence scientifically. And again, ask whether the patient is, many times when I ask the patient, are you taking it properly? The way they come out is, गोळ्या घेतो पण timing चुकतं. So that is a typical answer. So when they say that, then you know that he is not taking it properly. So ask, timing पण बरोबर राहतं का? कारण सांगतात सगळेच पेशंट घेतो गोळ्या. मग काउन्सिलर विचारतो घेतो का गोळ्या? हो घेतो गोळ्या. मग लिहिलं त्याने लगेच 100% एडरन्स. मग नंतर ससेप होते, मग विचारलं, खोलात जाऊन विचारलं किती वाजता घेता, काय घेता, मग सांगतं, हळूच उत्तर येतं, नाही टायमिंग चुकतं, कधी मध्ये टायमिंग चुकतं. मग परत खोलात जाऊन परत थोडं अजून चौकशी केली की कळतं की भरपूर गोळ्या चुकतात. मग मी गावी गेलो होतो, अमुक गेलो होतो. हे सगळ्या गोष्टी आहेत. त्याच्यामुळे अडिअरन्स सॉरी मराठीत बोलले कारण हे स्टेटचं आहे ना.
नाही पूर्ण गुजरात राजस्थान पण आहे.
अच्छा सॉरी. Oh, I am speaking in Marathi. I thought I didn't know it was for even the west region and other states. So ये बहुत जरूरी है कि पेशेंट का अडियरेंस जब हम पूछते हैं, काउंसलर्स पूछते हैं, तब पेशेंट सब हाँ ही बोलते हैं. नहीं, अगर आपने पिल काउंट नहीं किया तो आपको नहीं समझेगा. जब हम ऐसे ही पूछते हैं कि सारे गोली खाएंगे तो हाँ बोलते हैं. मेरे पास जो ससेप के लिए बहुत बार केसेस आते हैं, तब यही हमको डिस्कवर होता है. एक्चुअल ससेप में मैं पेशेंट को पूछती हूँ, लिखा होता है अडियरेंस 100%, 100%, लेकिन पेशेंट को पूछने के बाद पता चलता है कि टाइमिंग बराबर नहीं है. बाद में धीरे से पेशेंट बोलता है कि नहीं गोली नहीं खा रहा है. तो अडियरेंस के लिए पेशेंट के साथ थोड़ा टाइम बिताना पड़ेगा. तो जब भी डीटीजी रेजिमेंट पे वायरल लोड अगर हाई आ रहा है तो समझिए कि पेशेंट नहीं खा रहा है, क्योंकि इतने जल्दी रेजिस्टेंस नहीं आएगा. तो ये इसके लिए मेरा सब काउंसलर्स के लिए ये कहना है कि आपने पेशेंट के साथ टाइम बिताइए, बराबर एडहेरेंस हो रहा है कि नहीं पूछिए, पिल काउंट कीजिए. पिल काउंट कैसे करना है हम अभी ये लेक्चर के एंड में हम बताने वाले. So adherence to ART must be assessed at each visit and adherence must be reinforced through counseling at each visit. Adverse reactions of ART or OI drugs must be seen. Drug-drug interactions, looking at all the concomitant drug use, whether the patient is prescribed or he's taking over the counter. Over the counter यानी पेशेंट कभी-कभी मल्टीविटामिन्स किसी से ऐसे ही ले रहा है, खुद से ले रहा है, तो ये हमें पूछना है, क्योंकि मल्टीविटामिन्स का हमने देखा डीटीजी के साथ इंटरेक्शन है. Also look for iris. Then coming to immunological monitoring. So CD4 testing should be done every 6 months. So as routine virological monitoring is available, now CD4 testing should be done every 6 months and can be discontinued in those PL-HIV where the CD4 count reaches more than 350 and the plasma viral load is less than 1000 copies, when both tests will be conducted at the same time. So in such cases, once yearly CD4 and viral load can be done. But the exception for this rule is those who have HIV-2 infection. HIV-2 infection, we all know that the viral load is never detected. So there we are depending on immunological monitoring to detect failure. So that's why in HIV-2, we definitely should continue doing CD4 every 6 months. Then coming to virological monitoring. So at 6 months and 12 months after ART initiation, we have to do the viral load, and thereafter every 12 months we have to do it. PLHI with plasma viral load which is suppressed less than 1000 should continue the same ART regimen. PLHI with plasma viral load report more than 1000 should undergo step-up enhanced adherence counseling for 3 months. That is very, very important. Again, I am getting a lot of SUSEP referrals where their adherence is just reported as more than 95%. And I don't know whether proper step-up counseling is done or not. After 3 months also, it's the same. The viral load is still high. Remember that once the viral load is high, please talk to the patient, ask for adherence, explain the importance of adherence, and then only the viral load should be done repeat after 3 months only if the treatment adherence is more than 95% for 3 consecutive months. So in that case, then we can repeat the viral load. If the adherence is not more than 94% for 3 consecutive months, it is no use repeating it after 3 months because it is going to be high. And unnecessarily, it's reported by counselors as 95%, and we end up in changing the regimen. So please remember, we cannot do these things. We cannot easily just change a DTG based regimen like that. So we have to be very serious about it. Please note, if your patient is failing on TLD, it is actually not failure, it is non-adherence. So talk to the patient and do proper step-up enhanced adherence counseling. So if the repeat plasma viral load is after step-up EAC is less than 1000, patient should be continued on the same ART regimen. If the repeat plasma viral load report is more than 1000 copies per ml, then the patient should be referred electronically to SUSEP or e-SUSEP for further management. Now the problem with e-SUSEP is, which I am facing, we are getting a lot of e-SUSEP cases where the viral load is high on TLD based regimens or DTG based regimen. And if I just believe that 95% adherence, which is this looking on paper, it looks very perfect. 95% or 100% adherence to viral loads more than 1000 copies. So it is very easy for me in one stroke, I can change the patient from first line to second line. But I am doing this effort. I am taking actual SUSEP, talking to these patients online, and then I have realized that definitely there is an issue in adherence. In 95% of cases where the viral load is high on TLD, the patients are not adherent. So many times they are not confiding. अगर पेशेंट ने वो डब्बे में से गोली ली नहीं और वो गोली फेंक दी और तो आप वो एम्प्टी डब्बा लाएगा तो आपको लगेगा कि कुछ नहीं, एक भी पिल वापस नहीं आई है तो पेशेंट अडहेरेंट. तो अज्यूम मत कीजिए. अगर वो गोली वापस नहीं आई है इसका मतलब ऐसा नहीं कि पेशेंट ने पक्की ली है. तो हमें पूछना है, पेशेंट से थोड़ा बात करना है. अगर आप 10-15 मिनट पेशेंट के साथ बिताएंगे, ऐसे पेशेंट, मैं बोल रही हूँ सब पेशेंट में पॉसिबल नहीं, लेकिन जिनके वायरल लोड ऐसे डीटीजी बेस्ड रेजिमेंट पे हाई आ रहे हैं उसके साथ आपको टाइम बिताना बहुत जरूरी है. नहीं तो ये ऐसा ऑन पेपर ई-SUSEP पे बहुत परफेक्ट दिखता है, 2 वायरल लोड हाई दिखते हैं और अननेसेसरली पेशेंट को सेकंड लाइन रेजिमेंट दिया जाएगा, उसमें पिल बर्डन बढ़ेगा और पेशेंट का इश्यू सॉल्व नहीं होगा. तो ये मेरा सबसे बहुत इंपॉर्टेंट टेक होम मैसेज है आज का. So monitoring, this all of you know, so I'll just quickly go over that. So on tenofovir based ART, very important, baseline serum creatinine and 6 monthly, every 6 months we have to continue. But act on that serum creatinine. If you find a creatinine which is more than the baseline, like creatinine is now climbed up to more than 1.2. So even if it is 1.3, 1.4, please act on that and timely need to change the ART so that patient will not have irreversible renal tubular damage. Again, urine for protein, yes, at baseline, at 6 months and then every 6 months. For zidovudine based ART, बिकॉज सेकंड लाइन में कभी थर्ड लाइन में भी जीरोडिन होता है, तो जीरोडिन बेस्ड ART अगर है तो CBC baseline yes, then after 15 days, then first month, then third month, and then 6 months, and then every 6 months. For efavirenz containing ART, lipid profile at baseline and then at 12 months. Atazanavir containing ART, LFT and lipid profile at baseline, 6 months, then every 6 months. Lopinavir containing ART, lipid profile and blood sugar, baseline, 6 months, and then every 6 months. Dolutegravir containing ART, we have to do the baseline liver function, that is SGPT, and blood sugar at baseline, and then do it every 6 months. Now coming to stable adults and adolescents, what is the definition? So PLHIV, either adult or adolescent, shall be termed stable if they fulfill all the following criteria. No adverse effects on ART for 6 months, no adverse effects of ART that require regular monitoring, no current illness or OI or medical conditions which require monitoring, and suppress viral load. That is, in the absence of viral load monitoring, if it is not available, then rising CD4 cell counts or CD4 more than 200 and adherence more than 95%. Then coming to IRIS. Now IRIS, will not be possible to take in details. I will just so the definition of IRIS is worsening of signs and symptoms due to known infections. So suppose patient has already TB, now it is worsening, or development of a new OI due to occult infections within 6 months to 6 weeks to 6 months after initiating ART with an increase in CD4 count. So this is a condition that can occur shortly after a person starts ART, and it is a spectrum of clinical signs and symptoms because of the increased inflammatory reaction mounted by the body. So what are the risk factors? People with CD4 count below 100, they are at risk. People with rapid initial fall in HIV viral load due to therapy. People with diagnosis of another infection before starting the therapy. The closer the appearance or diagnosis is to starting the therapy, higher the risk of IRIS. Severity of TB disease, especially high pathogen burden and short interval between initiation of ATT and ART. Male sex, younger age, higher HIV RNA at ART initiation, and genetic susceptibility. So the main types of IRIS are infection unmasking. The main types of IRIS are infection unmasking. Means here the patient did not have any opportunistic infection before he was started on ART. And here the antigen target is viable replicating infective antigen. So he had an occult infection and that got unmasked after ART started. So ART start करने के बाद अगर TB हो गया, PCP हो गया, तो ये infection unmasking हुआ. Then infection paradoxical, where the antigen target is dead or dying organisms. So paradoxical IRIS यानी क्या? Patient को already से TB था और फिर हमने 15 दिन के बाद अभी ART चालू किया और अभी वो TB बढ़ गया, यानी पहले सिर्फ प्लूरल एफ्यूजन था, अभी बाकी सब USG नॉर्मल था, सब कुछ था, लेकिन ART स्टार्ट करने के बाद पेशेंट को एब्डोमिनल कॉक्स TB भी हो गया या प्लूरल एफ्यूजन रैपिडली फिल होके बढ़ने लगा, पेशेंट ब्रेथलेस हो गया, तो ये हुआ इन्फेक्शन पैराडॉक्सिकल. Then you have autoimmune type of IRIS where the antigen target is host. तो टिपिकल यानी रूमेटॉइड आर्थराइटिस है पेशेंट को, तो जब CD4 कम था तो रूमेटॉइड आर्थराइटिस एकदम ठीक था, यानी पेशेंट को कुछ आर्थराइटिस की जॉइंट पेन्स नहीं थे, और सडनली अभी ART स्टार्ट करने के बाद 3-4 महीने में CD4 बढ़ गया तो पेशेंट को आर्थराइटिस का वापस तकलीफ हुआ. Malignancies, the malignancy can increase, so the target is possible tumor or associated pathogen. Now unmasking IRIS, I already explained all these things. IRIS should be diagnosed by excluding the following: active OI. So we should rule out the following before we say it is IRIS. So active opportunistic infection or treatment failure or side effect from ARV or failure to antimicrobial therapy. So following can help in the diagnosis of IRIS. So how do you know that this is IRIS? Temporal association between the initiation of ART and development of new clinical event, mostly within the 6 weeks to 6 months. So typically IRIS occurs within 2 to 12 weeks of the initiation of ART, although it may present later. So the incidence of iris is estimated to be 10% among all patients in whom ART has been initiated, and up to 25% in among those initiated on ART having CD4 cell count of below 50. So any patient whose CD4 count is very low, we should be expecting an iris. We should be on guard. Now, unusual clinical manifestations in patients responding to ART include following. So you can have unexpected localized disease like lymph nodes. So lymph nodes may suddenly enlarge. So appearance or enlargement or suppuration of that lymph node, or involving liver or spleen, or development of pleural effusion. Exaggerated inflammatory reaction like severe fever with exclusion of other causes. Painful lesions. Then atypical inflammatory response in affected tissues like granulomas, suppuration. There can be a lot of suppuration and necrosis. Perivascular lymphocytic inflammatory cell infiltrates. Progression of organ dysfunction or enlargement of pre-existing lesions. So there were, suppose, tuberculomas, and now they are enlarging. Development of enlargement of cerebral space occupying lesions after treatment. For example, cerebral cryptococcus or toxoplasmosis, they are increasing in size. Progressive pneumonitis or development of organizing pneumonia after treatment for pulmonary TB or PCP. Onset or worsening of uveitis or vitritis after resolution of CMV retinitis. So all these things can be because of iris. Fever and cytopenia after treatment of disseminated MAC. Now, how do we manage iris? Mild form, we can just observe. Localized iris. So before we decide to manage iris, we have to rule out any drug resistance. So suppose it is a TB case, we should document the gene expert and rule out MDR TB, and we should also screen for any new OI. So mild iris, it is observation. Localized iris with ongoing ART, we can just do some local therapy like minor surgical procedures for lymph node abscess, so non-dependent drainage of the cold abscess, or as per the system involvement like for neurological, respiratory. Especially neurological iris, we should remember that steroids are very important. So suppose we say that cryptococcal meningitis, we do not start ART for this fear of iris. But suppose we have completed treatment and we started ART and again patient develop headache, and it's like looking like iris, then giving steroids is important in that. CNS iris, very important to start steroid because there can be raised intracranial tension. Respiratory iris also, like PCP iris, steroid may be required. And most of the situations with ongoing ART can be managed if you recognize and manage the infections. For fever, we can give a non-steroidal anti-inflammatory treatment. Antimicrobial therapy is required to eliminate the triggering pathogen or the antigenic load. And for reconstituting immune reaction to non-replicating antigens, there is no antimicrobial therapy required. Temporary cessation of ART may be considered if it is a very fulminant CNS iris or say CMV retinitis where there is a vision threat in that, with threatening of vision or life-threatening forms of iris, then in that case, like CNS iris, we can stop the ART for some time. And as I said, short-term therapy with corticosteroids in the dose of prednisolone at 1.5 milligram per kg for 2 weeks, followed by 0.75 milligram per kg for 2 weeks, and followed by tapering off, can be considered, especially for CNS iris and CMV retinitis where vision is involved. So in such cases, such types of iris. So I think because of lack of time, we will not be able to cover adherence. So if there are any questions, we can address for this part.
Thank you, ma'am. Participants are requested to please put their questions in the chat box so they can even unmute their mic. Since this was a lengthy session, we'll have the adherence to ART session next week. Any questions from the participants? किसी को कोई सवाल पूछना है? डॉक्टर पांडुरंग पाटिल सर, आपने माइक अनम्यूट किया है, कोई सवाल पूछना है? Ma'am, I don't think there are any questions. Kiran sir, do we have the feedback poll? Yes. Participants are requested to please attempt the feedback poll. There are 4 questions in all. Please scroll through the screen and answer all the 4 questions.
Next week है चला से चालू करते
Sorry. Next week don't talk. Next one.
Participants are requested to quickly go through the feedback poll. A small announcement for all the participants. RDLS सेशन अटेंड करने के पहले आपके सीनियर मेडिकल ऑफिसर या मेडिकल ऑफिसर या जो कोई भी स्टाफ अवेलेबल हो, उन्हें प्री टेस्ट फॉर्म भरना है. ये प्री टेस्ट फॉर्म की लिंक आपके ईमेल पे आई होगी, तो प्लीज प्री टेस्ट फॉर्म भरना है. और जब हम रिकॉर्डिंग भेजेंगे उसके साथ हम पोस्ट टेस्ट की लिंक भेजेंगे, तो वो पोस्ट टेस्ट फॉर्म फिर से भरना होगा. और ये सारा जुड़ेगा आपके अटेंडेंस के साथ, क्योंकि हम नैको को सबमिट करते हैं कि स्टेट वाइज पार्टिसिपेशन कितना था, उसमें से कितने लोगों ने प्री टेस्ट भरा था, कितने लोगों ने पोस्ट टेस्ट भरा है. सो प्लीज मेक श्योर कि आप ये प्री टेस्ट और पोस्ट टेस्ट टाइम से भरें. किरण सर, वी कैन एंड द ई-पोल नाउ. Thank you, ma'am. Thank you so much for facilitating this session. Thank you to all the participants for patient listening. The session on adherence to ART will be conducted next week, and we'll let you know the date soon. Thank you, ma'am. Can we conclude the session, ma'am?
Yeah, thank you so much. Only I'm very sorry that I spoke
No,
in
ma'am.
Marathi. I was not aware.
No problem, ma'am. No
So
problem.
next time I'll
Thank you,
remember.
ma'am.
Thank you. Okay.
Thank you, ma'am.
Yeah.